There you go.
So can you all see my slides as a slideshow?
Yes.
Yeah, okay. Right, so I'm talking to you today about a study day that I went to, I think it was last month, about promoting equity through research in palliative care. And they titled it, I can say if I can see this right, Sorbono, which means I see you in Zulu. And the ethos of this study day was where people feel known, especially in respect of any ethnically or culturally driven values or stances, greater trust can be engendered and lead to care that is more relevant, timely, and personalised. And I got this sort of slide, so it doesn't when it's sort of blown up to a bigger size, it's a bit rough and ready, but I think people have probably seen these kind of images. There's a variety of them with people looking over a fence or on bikes and things like that, about the difference between equality and equity, where equality means everybody is treated the same, whereas equity is about everybody getting what they need to get to the same outcome. So some people might need more, some people might need less, some people might need something that looks different, but it's about giving people what they need, so everybody reaches the same outcome rather than uniformly just giving everybody the same. These are just, there were many talks at the study day, but these are the ones that I'm going to talk on a bit about, what we learned through COVID. There's a couple of talks around COVID, bereavement, and then sort of reaching out to communities of sort of diverse ethnic backgrounds to sort of try and get their views about healthcare, death, dying, hospices. So the first talk was around what we learned from the COVID-19 epidemic. Professor Parikh sort of took us through the whole sort of COVID sort of journey and how we sort of slowly sort of began to understand that some ethnic groups were having much poorer outcomes. I haven't shared all of those slides because it was really interesting and fascinating, and you'll see at the end, anyone can watch this study day. It's available online and I've provided the links. But what I've tried to do is just pull out the nuggets that I found quite interesting from all the talks, rather than sort of replicate all of the talks, because obviously it was a full day study day. But he started talking about how ethnic diverse groups have always, in a way, had poorer outcomes. And this is a study from well before the COVID pandemic, from 2015, looking at New Zealand, about the mortality rates of the indigenous Maoris compared with the Europeans during various pandemics through the last sort of 100 years or so, from the 1918 pandemic to one in 1957 and one in 2009. And you can see the mortality rate for the Maoris was always far higher than the European group. I don't know if there's something good that disparity is slowly reducing, but it's still quite marked. And then this was all before COVID. And he said, knowing, well, this information was already out there, but they were quite slow on the uptake with COVID to really realise that there were these disparities, and it took a while for the information and data to come in. He talked about, when we think about ethnicity, it's a social construct, and it's made up of a variety of factors. So from genetic factors resulting in different skin colour, hair colour, eye colour, genetics relating to disease susceptibility, or how drugs are, how we respond to drugs, it's all around cultural identity, and that might be from a sort of a place of origin, might be around religion. There are behavioural patterns as well, about how people live, work, perceptions, their experiences as well. So experiences, and it might be their own experiences or a sort of a cultural history of inequality, racism, and things like that make up sort of ethnicity. So it's more than just one thing. So in itself, it's quite a varied factor, which then can impact on healthcare in a variety of different ways. So what gradually became apparent over the COVID-19 infections was that some groups were disproportionately affected. So South Asian and other ethnic groups had increased risk of death. Asian and Black groups had increased risk of hospitalisation and death. And depending on the studies, some picked out, I think in a lot of them, South Asian had worse outcomes. Some it was Asian and Black groups, but so that's why there's some sort of the wording is slightly different in some places. And they were trying to sort of understand why this was. And again, thinking about ethnicity as more than just one thing, the reason behind this disparity in outcomes, again, was very varied. So they found that the infection risk was higher, particularly in Asian and Black groups, and that was partly because of things like household risks. They tended to live in multi-generational households. And again, one thing from this talk is ethnic diverse cultures are diverse. So what's the situation in one culture or one group isn't always the same in others, but as a whole, there was more multi-generational households in this group than there were in the sort of the white British households. Occupational risk was higher. There was more front-facing staff, and again, this isn't just healthcare staff; it's bus drivers, carers, shop workers who going out to work. And there were more frontline workers living with other frontline workers, sort of increasing again the infection risk. There was deprivation, increased amount of deprivation, more likely to need public transport to get to work. So again, increasing their exposure risk. Their social networks were different. He talked about the public health messaging wasn't really targeted for these groups, didn't really speak to them. Levels of discrimination, institutional and other types of discrimination. And that all sort of led to increased exposure to the virus and increased infection rates. And then what translated to then increased hospitalization rates, ITU and death, was more of the comorbid profile of some of these groups, like higher rates of diabetes and high blood pressure and other things like that. So there was multiple reasons why these groups had a much higher risk. Which I think is what that slide said. And he then went and talked a lot, which I haven't included this, about ethnic diverse groups working as healthcare workers and their experiences. But I would suggest, if you're sort of interested in more of this, to look at the study day link at the end. There was a couple of talks about bereavement support in ethnically diverse communities. There was one that was exploring experiences of Caribbean communities, and I think these were in the Midlands, and one looking at ethnic diverse communities in Wales. And again, from the outset, it was said that we know that ethnic diverse communities have worse health outcomes for a variety of reasons, and this includes complex sort of brief reactions. And the voluntary bereavement service had issued a report and was aware that there was people from ethnically diverse communities had unmet bereavement support needs. And again, they wanted to sort of try and understand this more, about the barriers to gaining bereavement support. So that's what these sort of two studies were looking at. This is the one talking to Caribbean communities. And again, there was lots of quotes and lots of things they said, and I've picked out a few that really I thought were interesting. There was one about the concept of family. And again, I think in hospices, we tend to think of family as more than just the immediate family. But again, it still made me sort of think about how supportive we are and their experiences. And this quote was, I might just have to move that so I can actually read the quote, was from a woman who was a single parent. And she said, I was a single parent. Although as a single parent, the understanding of single parent and the Western understanding of the single parent is single parent and that they're on their own. There's no one else. We don't do that. He had male role models around him his whole life. Always he had his grandparents. He had my brothers, uncles, aunts, cousins, whatever. And then one of his biggest attachments was to my father, who was the deceased. It had a huge knock-on effect for my son. Even though he had his uncles, he lost his dad. I lost my dad. He lost his dad. So her father was a father figure, obviously, to her and also to his son. And she found it frustrating, this concept that because she was a single parent, she was isolated and alone. And she felt, no, she was surrounded by family and well people. And it's that sort of understanding of family can be very different. And the implications of this sort of misunderstanding of what family means to different cultures. There was a quote from someone, I think it's sometimes belittled, particularly in hospitals where you've got your loved one. They're expecting 2 or 3 people to come, but actually the family comes, cousins and everyone, and they say only 2 people by the bedside. But it's like, no, my uncle is dying. He wants everyone around him. And it's not the first time. We're not the first Black family who's died in hospital. And then they also went on to say, it's quite telling with employers. There's a joke, oh, who's died this time? They weren't close to you, but it's family. And when I say my auntie and uncle has died, they want to know if that was your immediate. They are my elder, it's uncle, it's auntie, and I'm not going to explain it again. That's all you need to know. It's my auntie or uncle. So again, it's us sort of understanding these larger family groups than perhaps we have experienced and what it means to the individuals in that family, for the patients, and the family members. They talked about some positive examples. This person, I don't know who it is. I don't think it's a patient or relative, but we've been launching a bereavement policy and we've tried to accommodate the different needs for different cultures because everyone is impacted with death and dying. And that's one of the things we spoke about. How much time do you give someone and what does it mean? Because grieving means different things. And we're trying to make it so people don't feel they can't go or they have to use their annual leave. But there is something meaningful in what we were able to offer them. And it allows them to have that support without thinking they've got to rush back to work. Then we can offer them support. And another quote, a good funeral director can make all the difference. The funeral directors know all the different communities. They've got a big Italian community, they do it their way. Big Asian community, they do it their way. Black community, do it their way. And they've got it on point to deal with every community and how to deal with them, which again is an example of dealing with, not dealing with everybody the same, but dealing with everybody so you meet their needs. And that might mean you have to offer different things to different groups. This then was from the group looking at an ethnic diverse community in Wales. And they were speaking about language barriers and how that can complicate caring and looking after people if they don't speak English. But it's also how it's not that simple to always get over. The first quote is about using a family member, and this is an example of using a child as a family member, which I don't think we would ever use an 8 or 10-year-old family member to interpret, but we do often use family members because they're there, it's easier. They might have been in that role for that relative, you know, for a long time and they're used to translating for them. I think if we think it's going to be a complex or difficult or like an important ACP conversation, we do try and get external interpreters, but they did highlight how that can sometimes be difficult because in some groups it can be you have to get someone possibly with the same sort of dialect. So they gave the example of someone from Pakistan who speaks Urdu. It depends what part of Pakistan they come from, because there are different dialects in the sort of Urdu, and they might not be understood all over. So you've really got to make sure that it's an appropriate interpreter who can communicate with the individual. And I know that we found that sometimes with the Gurkha population is finding somebody who can interpret, who's not well known to the person, because if they're from their community, then that you have the confidentiality issues. The second quote I think was also a bit quite interesting about sometimes there aren't straight translations of terms. I think there are real nuanced differences between how things translate. In my language, for example, anxiety doesn't directly translate. You might say something like heart tremors, which someone else might think, what does that mean? And the person giving the talk also highlighted that in some ethnic groups, particularly in certain generations, there's a high rate of illiteracy as well. So if you do a leaflet in the appropriate language, that doesn't mean that necessarily the right people can still access that information or read that information. So with language, it can be quite complicated to get it right and in the right form. They talked about, and a number of talks talked about stigma and taboo in some cultures, particularly around death and dying and grief, and around certain conditions, such as here they highlighted somebody who died of suicide, and that being a big taboo. If somebody died by suicide, there can be a stigma in some cultures. I worked with a young woman whose brother had died by suicide, and the family would not talk about him at all. That was the end of it. And then it's really difficult to access support then, because it's the shame, it's the stigma. And they said other things, that if people die from alcohol-related reasons or drug-related reasons, again, there can be a big element of shame and taboo in the cultures. There was talk about challenging engaging some men in some cultures, although it was highlighted again, it can vary between first generation immigrants and second generation who have been born and raised here. And this is a quote from somebody: what I see from the next generation, the second generation Asian minority, because they've been brought up here with British values and culture, they're more acceptable to the fact that yes, it's happening, and yes, it's not normal, and yes, I do need help. It was highlighted that when you're trying to reach out to some groups, it's important to meet them where they are rather than expecting them to come to you. And I think there's been a lot of talk around sort of palliative care as public health and reaching out into the community centres, schools. And this was about religion as well, can be a conduit for some groups. And here it was the example of if an imam on a Friday sermon was to say, let's talk about grief and loss and bereavement and mental health and how they're linked and how they're separate, the Muslim men are far more likely to absorb that and to be able to allow themselves to grieve and to allow themselves to feel those emotions. Because often in Muslim communities, Muslim men are seen to be, there's this idea that you have to be strong, and by strong sometimes it's be emotionless. A counselling service in every mosque, temple, gurdwara, synagogue that there is, and it would just be specific to their faith, and if it's there, if you need it, and if you don't, if you would come in and have a chat. So there was lots about trying to meet communities where they are, rather than expect them to come to you and access your service. So here they were talking about the next steps in Wales, which I'm not going to go through that much, but one thing that I thought was interesting, they talk about at the bottom about early intervention in schools. Our children need to be aware of mental health loss, grief, bereavement, and family breakups. And I just thought I'd do a little plug, because that is what Claire Tune's article of the month this month is, and it's there on the Nest if you want to read it, about grief education in schools. So I just thought a little plug for article of the month there, as it was highlighted in one of the talks as something that is needed. So this was a talk by someone from Mary Curie, who was trying to understand, I think this was a North London, again, a mixed sort of ethnically diverse community, trying to understand from them their understanding of Marie Curie and hospice care and death and dying and what they need. And one thing that I found interesting with this talk was the terms used. Most people use the terms ethnic diverse groups. A very small amount of people use ethnic minorities. Nobody used BAME, which I think is now is not the term that is like to be used. But this lady, I can't think of her name, she used the term global majority populations, which I hadn't heard before. And this sort of groups together people whose origin is from the Southern Hemisphere, so South American, African, South Asian, that's where the majority of the world's population live. And that was a term that she used that I hadn't heard used before. Most speakers talked about ethnically diverse communities. As I say, very few people use ethnic minorities, although it was there in some of the slides, but it was mainly ethnic diverse global majority population. So, and that was something I hadn't heard before, so something else that I learned. And this is sort of a bit like a few summary slides of what she found in her qualitative work with these communities, and talked about filial cultures, so sort of respect your elder, sort of family structure, and also dyad decision making, which is normally male-led, which I think we sometimes see where families come together to make decisions. I think sometimes we can struggle with that because we're more used to individuals making autonomous decisions, but there's a lot more family dyad decision making. And although it's usually male-led, it was very much emphasised that doesn't mean it's devoid of input from the women who also input into the decision making, although it is often male-led. Again, this isn't every culture and this won't be every family. The fact that death, again, talking about taboos, is often spoken in euphemistic tones. I don't know, I can't see if Helen is here, but I know Helen hates that when people don't talk frankly about death, but they said lots of communities, they prefer to talk about transitions or use different terms for death and dying, which again can make communication sometimes challenging. For many, the concept of hospice is just very foreign. People die at home or they die in hospital. The understanding of what hospice is, that's something for rich white people, Christian rich white people. They're not quite sure what it has to do with them or what it could offer them. Again, we've talked about some stigmas around some diseases. And with that, some myths and mistrust around opioids and syringe drivers and things like that, and misunderstanding of what they are. Another thing that was, again, a thread through many of the talks was about pervasive institutional mistrust due to systemic racism evidenced in criminal justice system, employment, education, and how things that weren't anything to do with healthcare, like Grenfell, I haven't mentioned it here, but some of the quotes from some people mention things like Grenfell that have nothing to do in a way with healthcare, but it adds to the picture that institutions don't look out for them, aren't interested in them, their needs aren't being met, and that is sort of all pervasive and impacts on all institutions, including healthcare, including hospices. And that might be something for me, as somebody who is middle class white British, difficult to understand, that there is this pervasive feeling of things that they've either experienced themselves, their family have, or they've that they've read about, but it sort of speaks to them in a way it doesn't speak to me, that there's this sort of feeling of mistrust. And one thing again about the cultural memory of racist trials, in another slide, they talk about the Tuskegee trial. And I just want to mention this because it's just an example of how things we might forget, but in some cultures they sort of live on and have a huge impact about how people have been mistreated by white people in the past. So this was a trial, some of you might have heard, a syphilis trial in America running from the 1930s to the 70s, where it was about 600 impoverished Black men from Alabama enrolled in a study. They weren't really properly consented. They were told it would last for 6 months. It lasted 40 years. 400 of them had syphilis. They did not know and were never given the diagnosis that they had syphilis. 200 didn't have syphilis. And the study was supposedly to see what, how the disease affected the body when it was untreated. And they told them that if they enrolled in this, they would have access to free healthcare, which they otherwise wouldn't have. So it was taken up very, easily. And they gave them pseudo-diagnosis, told them they had bad blood, gave them placebos, did alarming sort of things to them to pretend that they were treating their bad blood. When penicillin was discovered and found to be an effective treatment for syphilis in the 1940s, they weren't given it. And they continued on. Many of the men died. They infected their wives. Children were born with congenital syphilis. And it only came to an end in the 1970s when details of the study were leaked to the press. So this is something that then was made public in the 70s. And these kind of things sort of live on in the, as they say, the cultural memory of sort of distrust of some groups, and understandable. It's not that long ago, and it's an appalling ethical study. So these kind of things can live on in some groups. And as one of the speakers later on said, she disliked the term saying these groups mistrust healthcare settings rather than institutions. It's more that we haven't earned their trust, and that we need to do more to earn their trust. So sort of moving on from that, just one more point on this page about autonomy, which was sort of referenced before, and about family decision making. There was also in some groups the real desire for clinicians to do the decision making, and how some cultures can find it really hard when there's really complex medical decision making and they feel that they're being asked to make a decision and they feel it should be clinician led or doctor led, and sometimes they feel the weight of that decision afterwards. Did they, especially if it's around life stopping treatment, did they make the right decision? Did they turn off the machine? Did they stop the chemotherapy? Did they make the right decision? And they don't understand why. They feel that should have been a medical decision made by medics. And again, that's something we need to understand and find out how individuals want the decision to be made. I think I'm probably going to have to move on from this. I think, again, it talks about, just briefly, about people feeling that if they don't, feeling invisible, and if they don't look like the people who are looking after them, when I don't look like them, will they care for me? And again, the fact that they didn't know, this was about a Marie Curie talk, and she said that they didn't know what the daffodil meant, and that sort of made me smile. And I just thought they don't really understand the concept of hospice care, then I don't think they're going to understand the Marie Curie daffodil. And then this was, what do global majority populations want from us? And again, there was a few bits that I picked out. They want to be taken seriously by healthcare professionals. Another thing that was a thread in a number of talks was continuity of care in hospice service was really important. A lot of people felt that they found a clinician who understood them, who they trusted, then they wanted or hoped that they would continue to see that clinician, and they found it could sometimes anxiety inducing if then a number of different clinicians were coming through, and they had to then rebuild that trust with each one. And so they really valued continuity of care. And another thing that I will talk a bit more in a later sort of slide about cultural humility in health and social care. So it's that sort of understanding your culture and a genuine wanting to understand the culture of the family in front of you. And that might be, you might think that you've cared for somebody of a similar culture, but as I say, even within sort of cultures, there's a lot of difference. You've really got to know the family and what their values are, how they make decisions, what's important to them, and try and understand where they're coming from. Now this was a really interesting talk, but I have to say I found it quite hard as a palliative care physician, because this was about ethnic disparities in the rates of opioid prescribing for cancer pain in the UK. And again, as a clinician, I like to think that we treat people's symptoms as they are in front of us, and it's based on the symptoms and their needs. And I will share these slides. These are just some QR codes of some papers that they shared, again, looking, because there's more and more work being done about the equity gap in palliative care. But we know that there are differences in how ethnic minorities sort of receive care and symptom control. And it was from some of the American studies about possibilities of why patient-related variables, including sort of biopsychosocial model of pain, cultural and individual differences, social determinants, language, cultural insensitivity, biological reasons around analgesic drug absorption, metabolism, healthcare system related variables. And again, this comes from American models. They talk about insurance companies offering less than optimal coverage, about neighborhood resources, and then healthcare provider related variables, including beliefs and expectations of patients, underestimating pain intensity for certain groups. Sorry, was that someone trying to ask something? And this is an American paper looking at inequalities in administration of opioids and non-opioid pains medication in US emergency departments. So this wasn't cancer or palliative care. This was people coming in after a road traffic accident with a broken leg, with acute appendicitis, coming in, and this was, again, over many years. I think it looks like it's from something in the 1999 all the way up to, I think, 2021. The orange line is white Americans and the green is black. So you can see that they are receiving less opioids for these when they're coming into the emergency department with a painful issue. So that was very much what was going on in America. There was this review of putting together evidence from English-speaking countries. And again, sadly, the story is the same, that there was the first one, Asian patients receiving significantly fewer opioid analgesics, Hispanics receiving fewer opioids, African American getting less active opioids, and again, non-Hispanic, Black and Hispanic and other ethnicities, again, receiving lower pain relief, and that the last one was in hospice patients. So what did we know from the UK? There was some qualitative evidence that, again, the perception of bereaved family members was that patients from ethnic diverse groups were not getting such good symptom control as they should do. And again, from the National Cancer Patient Experience Survey, consistently patients from ethnically diverse communities are less satisfied than white British patients in believing cancer pain was well managed. So Jonathan Kaufman, who was giving this talk, wanted to look at this in more detail. And they wanted to examine the relationship between, I'm going to have to keep moving where my little thing is so I can read, sorry, to examine the relationship between ethnicity and primary care prescribing patterns of opioids among UK cancer patients towards the end of life. So they looked at a large amount of data which they got from Clinical Practice Research Data Link, which was an anonymised database of recorded information representing over 16 million people from 650 GP practices throughout the entire UK. They used hospital episode statistics and information from the Office for National Statistics. And what they did was they looked at UK cancer patients who died from 2011 to 2020 who had a diagnosis of cancer. And their primary outcome was the number of opioid prescriptions the patients received in the final 3 months of life. And the secondary outcomes was number of emergency department visits and hospital admissions. This slide just shows that amongst all the ethnic groups, they were sort of weighted for the proportion of cancers in most groups was roughly the same. So it wasn't that one group had a more sort of painful cancer than the others. They were sort of all evenly sort of spread. And this isn't published yet, which is why he didn't want it on social media. I am sharing it here and it is available on the Loris website. But please don't, I don't think anybody here is likely to tweet this. But what it did show on this slide, again, the green line is the opioid prescription rate per 1,000 person months by patient ethnicity. And again, this is from 2011 to 2019. So the green line is the white population. And then the other colours are other ethnic groups. So the pink is South Asian. This sort of bluish colour is other ethnic groups. The orange is mixed ethnicity and the green line is black. And as you can see, really all ethnic diverse groups were receiving less opioids, and that's something that's not really improving. So moved on. And then they looked at the emergency department visit rate in the last 3 months of life. And again, the green line is the white British population. And as you can see, all the other ethnic groups were having a higher rate of emergency department visits in the last 3 months of life. Again, it's unclear why, but it could be postulated, is it because their symptoms aren't as well controlled as the other population? There could, and again, as we know, with ethnicity is a varied term that covers behaviours, genetics, culture, you know, but is that what's going on? So obviously the limitations of the study is that they were only looking at GP prescriptions. People could have been getting prescriptions from elsewhere, such as hospices or hospitals. The difficulty of working out opioid equivalents for some medications, and obviously there wasn't any information about pain intensity or effectiveness of the opioids. But they said it was an exploratory study, and it did show there was evidence of material disparities in community prescribing of opioids to manage cancer pain for patients from minority ethnic groups, and it shows similar to what they found in the US. It cannot demonstrate causation. However, relationship exists between community prescribing of opioids, patient ethnicity, and the use of healthcare services in the final 3 months of life. There was a higher rate of hospital admissions and A&E visits in the last 3 months of life. And so this has obviously implications for patient experience, outcomes, patient safety, and NHS costs. So I thought that was quite eye-opening and made me sort of reflect a little bit about my own practice and what we see. But I think it's, you know, it's quite hard on the individual level, but when you see it like that and see that there is a big difference, yeah, I thought it was quite eye-opening. So Then this talk was by someone from Loris, who put on the whole study day, where they have done work about trying to support healthcare professionals to make end-of-life care accessible for all. And they've come up with this, they've used the term Sora Bono. Sorry, did someone say something or no? And this, I think I did share on the medics WhatsApp group during that when I was there. I found this really quite interesting, the cultural iceberg. It was something that I hadn't seen before. I'm not sure how well it will show up on everyone's screen, but they talk about, again, what culture is or what ethnicity is. And there's things that are easy to see, such as language, religion, dress, food, but actually it engulfs sort of a lot more than that we might not immediately pick up on, such as approaches to health and medicine, concept of justice, expectations, manners, thought patterns, personal space, body language, just a whole lot more that we might not immediately perceive. And therefore, when we're caring for people, we need to sort of, as they say, have some humility and really try and get to know the people that we're looking after and what's important to them, and try and overcome some of the differences. And again, that's where tailoring sort of services to individuals is really important. And what Loris have on their website, which there are links in a minute coming up, is they, through some of their work, they have spoken to lots of people from different backgrounds about their experience of healthcare, and they have stories. Now, I don't know whether these are real stories or they've used these experiences and created stories, but they have a number of stories that you can listen to, little sort of video clips, and they played one for us. And again, they talk about what you see and what you don't see. And there was a patient who was in an inpatient unit, and his son was on the ward, and he came across as difficult and angry. And that's what was perceived. He was difficult to sort of communicate with, coming and going all the time. But what they didn't see was his concern that he's afraid of being deported. His employment is precarious and demanding. It was manual labouring, and if he didn't turn up for work, he would lose his job, so he had to go. He did not trust that professionals want to do the best for his father, partly from his other experiences in other places. He was scared. He feels guilty that he's not doing his duty by his father, that he's got to leave his father to go for work. So there were all these other issues that were bubbling away inside of him that wasn't really picked up on. And what was perceived was, there was an angry young man on the ward that it was very difficult to care and look after. And this term cultural humility was used by a number of speakers, and about having active listening, learn from patient narratives without assumptions or stereotyping. But also they talked a lot about being aware of your own culture and examining your own sort of unconscious biases, having an authentic curiosity. What do I need to know about you as a person to give you the best possible care? Not assuming because you've met one family before from the same background that therefore this family is going to be the same, really wanting to get to know and understand them. Embracing complexity and being aware that practice can be uncertain. And they use the acronym HUMBLE, which is basically all of those things. Humble about making assumptions, understand your own background, motivate yourself to learn about the patient's background, begin to incorporate this knowledge in your learning. It's a lifelong learning. You can't ever say, tick, I've done that, I know it now. Emphasize respect and negotiate treatment. They also highlighted there's an e-learning for health around this, and I think there are links to that on their website. This is their website where they have lots of resources, the stories where they've taken stories from people from different ethnic backgrounds and their experience of healthcare, which was really interesting. The one that they played is all available on their website. And if you go to the Loris Hospice website and you click on the Centre for Excellence tab, Under research, there's the Sorbonne conference, which is where all of these come from, and that's available. It's not, you don't have to have a password, and they have put the timings of all the talks. So if you just want to listen to one of the talks, you can scoot ahead. It's done in 2 videos, the morning and the afternoon session. So if you're interested about seeing some more, that's there. And the thinking ahead is under the research studies, and that's the little case studies where you can sort of see from individuals' point of view how they experience healthcare. And this is the last talk that was from Sabrina, who again, it's sort of around the COVID response. Some of you might remember there was CovPal surveys going around during COVID about palliative care response to COVID, and there was many arms to the survey, and one of them that Sabrina was working on was aiming to map and develop insights into the response of specialist palliative care services caring for patients and families from ethnic minority groups during the first wave of COVID-19 pandemic. And there were some questions about whether you've encountered patients or families with COVID-19 who are from ethnic minority groups. Are you supporting them? Are there differences in how you're supporting them? And are there groups where you found supporting individual needs sort of challenging? So there was a quantitative sort of yes/no bit about if you've cared for patients with COVID from ethnic minorities. And she highlighted how there was a lot more in hospital teams. And I had to say, she sort of said that therefore that might show that there are some barriers to hospice care. I think that, like, we were a cold site, so we didn't admit many patients with COVID, and a lot of patients with COVID did end up in hospital. So I'm not surprised that the hospital teams saw more people with COVID as a whole, and also saw more people from ethnic diverse populations with COVID. In some of the qualitative responses with the free text that they analysed, they noted that there was a disproportionate adverse impact of restricted visiting due to COVID. And again, part of that is the compounding the communication challenges, which they also found if people were reliant on family members to communicate for them, if they felt very vulnerable, frightened. Again, that mistrust of institutions, they're then there and they don't have any of their support mechanisms with them. And with that, there was unmet religious and faith needs, which might have been particularly important to some groups, the mistrust of services, and again, the focus on equal and personalised care. And she had this slide where she talked about sort of the blue line at the top is sort of trying to get to sort of good symptom controlled sort of care. That's the outcome that we're all striving for. And the served groups with an equal personalised responsive care, equal allocation of services, the served groups get there. She also talked about the people who is getting the best and the most. And this is this group who easily then get over the line. Whereas the underserved groups, those from different cultural backgrounds, even with the same care, then they're not getting to that line because you're not responding to their cultural and religious needs, which means there's which are impacting them more. So she talked about you need more of an equitable response, which is culturally congruent care with a fairer distribution of resources. It might not mean that everybody gets the same, but it's a fairer distribution, a participatory and inclusive approach to change, equality and impact assessments of policies and safeguards to mitigate the impact that these have. And that's an equitable response rather than an equal response. This is a QR code to the paper that came out of her CovPal work, and that has been quoted in these other public policies. This is a code to a video. I think it's about 25 minutes that she did talking to both healthcare professionals and people from ethnic diverse groups, their experience of healthcare and healthcare professionals' experience of trying to support and provide an equitable service. And again, this is free to look at via this QR code. And this is a QR code to again, e-learning for health module about equitable resources in sort of palliative care. So again, if people are interested and want to do a bit more, and as mentioned before, this is a link to the conference that is up on the Loris website if people are interested. I mean, one thing about this study day that was looking at equity, and it very much focused on ethnic sort of diversity, but we have to be aware that there's, to make our services equitable, there's more than just making sure that's for ethnic diverse cultures. Groups that weren't sort of covered or mentioned in this study is the disparity between people with different sort of social deprivation that they experience, and how they access healthcare, other sort of discriminated against communities like traveller communities, LGBTQ, and also others that might need a different kind of provision for them, people with learning difficulties, neurodiverse groups. So again, this was looking at one group of people that might have difficulty accessing healthcare for a variety of reasons, and we need to think about them as the sort of marginalised group, but there are other marginalised groups as well that weren't mentioned in this study day. But I just found it really interesting, and just so wanted to share it with people. I'm going to stop sharing my screen now, and I hope there's still people there. So I don't know if anybody has any thoughts or questions. No.
Just to say, Jo, super amount of information, very good presentation. Yeah. But I don't have any questions, thorny questions to give you.
And I know there is a lot. That's why I put the links there. I mean, like the COVID talk, which I didn't really go into any detail, was so interesting, but I didn't think it, I thought it was interesting, but there wasn't many nuggets I could take away. But I would strongly recommend people just going and having a look and seeing some of what they had to offer, and some of the videos and things, the resources that are there, to really make you think about how we're supporting these different groups and families that sometimes I think we do find difficult, because that how they make decisions, the family groups, sometimes we think they're chaotic. We go to the home and there's sort of so many people in the house, and I think we have to sort of stop and think about how we support these families. Be really careful we don't label people as difficult just because we don't understand how they're perceiving us, and realizing that they have had lots of trauma or difficult interactions with various institutions, be them healthcare or not, and we're coming at them at a vulnerable time. And so make sure that we are open and genuinely trying to get to know them where they are, and not label people as difficult. Yeah.
Yeah, thanks, Jo. I found it really interesting as well. We've had experience recently on the inpatient unit looking after people from different backgrounds, and sometimes it's a real struggle to try and meet either their religious needs or get interpreters in a timely fashion, and some of the struggles around fear of being deported or being an illegal immigrant is quite tricky. So no, it was really interesting. Yeah, and the other thing I was just reflecting on, I'm reading this book at the moment called Unwell Woman by Eleanor Cleghorn. I don't know if anybody else has read it. Just I can only read about a chapter at a time because it makes me so cross when I'm reading it. So just looking at how women have been marginalised and their healthcare needs have not been met, and all of that. And I just thought, gosh, that would just double down so much if you were also from an ethnically diverse culture and a woman as well. So yeah,
and that's what they said. Sometimes these sort of factors sort of cross each other. So you've got the gender bias, you've got the social deprivation bias, you've got the cultural bias, you've got the language bias, and they're all sort of interacting and compounding. Making it even harder for these groups. And so when we say we want to reach out with them, we've really got to think how we do that. It's more than just getting a leaflet in their language. It's really thinking from their point of view, and as a lot of them said, meeting them where they are, and that might mean going and doing work outside of the sort of the hospice and meeting them elsewhere and trying to understand their needs and how all sort of different cultures and communities are different. So you need to know the community in your area, and then family by family when you're looking at them, their needs.
Yeah,
But I would
interesting.
recommend looking at those links. I think Nikki will send round the slides.
Oh, thank you.
I think they call that intersectionality.
Oh,
That's
okay.
when you have a
That's
number of
big one.
different things compounding.
Yeah,
Mm.
yeah.
I'll write it in the chat.
Okay. And also just a plug, I don't want to do it for other speakers, but there probably will be a feedback link, so please complete that for me as well. Okay. All right, thank you. I thought I was going to run over, but okay, bye.
Thank
you.
you.
Bye,
Thank
Jane.
you.
Thanks a lot.
Bye.
Bye.